first person up is Dr. Sarah Stroud, and she's going to be presenting abstract on factors associated in high-grade extremity sarcomas.
Thanks, everybody. Thanks for having me, and thanks to Dr. Wistrak for being my research mentor. So I'd like to talk about prognostic factors for patients with high-grade extremity sarcomas in a California population over about a 30-year period. This presentation was funded by an OREF grant. We have no other relevant disclosures. So there is data in other sarcoma populations, many of which include the axial skeleton, that basically suggests that low-income and publicly insured patients consistently have higher mortality rates. There's some evidence that Black patients with extremity sarcomas have higher amputation rates. And the effect of individual racial group identifications on survival is a little bit unclear. And again, many of these studies will lump all non-white patients in and compare them to white patients, or will include axial pathology, so not a totally clinically clear picture. We theorized basically that a high-grade extremity sarcoma is a resource-intensive process to treat, and as a result might increase a patient's exposure to the healthcare system, and it might precipitate or elucidate some of these existing sociodemographic disparities. There is recent evidence, including a paper by Dr. Goldsby and Dr. Wistrak out of UCSF, that suggests in the PEDS population in California, insurance may account for some or all of the detrimental effects of non-white race that we see on mortality. And obviously kids represent a slightly different insurance population than adults, but we wanted to follow up on that finding. So we set out to ask, are non-white race, public insurance, and low neighborhood socioeconomic status, which was our proxy for individual SES in this study, associated with amputation rates or mortality in a high-grade extremity sarcoma? We did a 30-year review of the California Cancer Registry. It's state-regulated. It captures almost every non-skin cancer diagnosed in California. We collected patient, tumor, and treatment data. We split neighborhood socioeconomic status into quintiles for a binary variable. We used 1 through 3 as low and 4 and 5 as high. Uniquely for this paper, the two things that stand out, I think, we defined evidence-based standard treatment paradigms for each histology, so chondrosarcoma, Ewing's osteosarcoma, as a bit of a quality check variable to say, did this patient get the appropriate treatment? If not, is that one of the underlying mediator variables? And then we had a professional statistician do sequential modeling to look at essentially how each of those three variables of interest interacted. So how did socioeconomic status and insurance affect the effect of race on mortality? We captured about 7,200 patients. The mean age was 57. We found that white, Black, and Hispanic identified patients didn't differ in the rate of the standard treatment kind of quality check variable, but Asian patients were significantly more likely to receive the standard treatment for their condition. The amputation rate was highest among Black patients. It was more than 1.5 times the rate of white patients. The rate of amputation in Medicaid patients was twice the rate of amputation in privately insured patients. Mortality was significantly lower among Asian and Hispanic patients, which has been reported in some prior studies in other sarcoma populations, and that's compared to white patients. We did find that mortality was the highest among Black patients, and it was significantly higher than white patients. And then sort of replicating other studies in other cancer populations, low neighborhood socioeconomic status and public insurance were unsurprisingly associated with worse outcomes. This is a graphic depiction of the sequential modeling. So hazards of death by Black race essentially are on the y-axis. You can see that for the addition of each variable into the model, there's sort of a change in that effect. Extension, so stage of disease, had the greatest interaction with Black race and the greatest contribution, we think, to their excess mortality. Neighborhood socioeconomic status, more so than insurance status, but both of those also contributed. There are figures like this for the Asian racial identification group and Hispanic group as well, but the directionality of the socioeconomic status and insurance variables were actually inverse, meaning those variables appear to be somewhat protective in those groups and may partially account for the lower mortality. So in sum, despite receiving standard treatment for their extremity sarcoma at the same rates as white patients, Black patients have excess mortality. They have higher amputation rates. Asian and Hispanic patients seem to have lower mortality in this condition compared to white patients. And again, this is a California population, so there may be sort of like unique cultural enclaves here that are not necessarily generalizable nationally. Public insurance, low neighborhood socioeconomic status are likely accounting for some of those racial disparities that we see. I think next steps for me personally as I move forward in my career are going to be applying some of these tools to other subspecialties in orthopedics because we know that these disparities exist there. Thanks for your time.
Awesome, thank you. So next up we have Dr. Marcus DeLallo. He's hopefully going to convince us that we should all be incorporating CBD into our practice.
Great. I'm not here to push any products on anyone, but this is the utilization, perceived effectiveness, and interest in topical CBD amongst patients with hip and knee arthritis. I have no relevant disclosures. CBD is a non-psychoactive component of marijuana. It can be taken a number of different ways. You can apply it topically, you can ingest it, it can also be inhaled. It's associated with many analgesic and anti-inflammatory effects. It is a component of marijuana, which is a Schedule I drug on the DEA, and you can see the other drugs that are up on the list there, including ecstasy, heroin, LSD. Because of this, it's been kind of slow moving in terms of research that's looked into the use or the therapeutic uses for CBD in the medical community. Evidence-based knowledge of the current use lacks for this reason. So the aim of this survey was just to query patients about their personal use and their perceived effectiveness of using topical CBD for their arthritic pain. Pretty simple methods here. We gave a voluntary anonymous survey, 17 questions to new patients presenting into arthroplasty clinic. We just collected this over about a year. We took the first 100 respondents. It was patients with native knee arthritis. There were no, we didn't query patients that already had a joint replacement in place. And we were just asking patients about their knowledge of their personal use and their perceived effectiveness of using topical CBD for their arthritic pain. Responses were collected on REDCap, and then we just did some very simple statistics to compare the groups here. Some basic demographics. Like I said, the surveys were completely anonymous, so we couldn't comb through and find any more deeper demographic information about patients, but we could split them male and female, and also we collected their age in that survey. So you can see here there was no significant difference between age between CBD users and non-users. There was a significant difference regarding gender, with more women having tried CBD for pain relief. So the cohort was split, like I said, there was 100 patients, 60 had tried CBD, 40% or 40 patients had not. This is the breakdown for reasons why they had not tried it yet. About a quarter had never heard of it. Some had no interest. Some were aware of CBD, but they weren't aware that it could have anti-inflammatory or analgesic properties. And then the most common reason, about half of the patients said that it wasn't recommended to them by a physician, so they didn't feel safe using it. The other 60 that had tried it, you can see the breakdown of the frequency of which they used it. 70% of those patients reported some sort of pain relief, and over 3/4 reported that CBD was as effective or more effective than pain relief than other over-the-counter or prescription topical medications, things like Voltaren gel. 92% reported that they would likely or definitely use a topical CBD preparation if it was offered by a physician. And only 3 users reported a side effect, decreased energy and hunger. 1 person experienced both of them. There were some limitations to this study. Obviously, we all live in San Francisco. We know the patient population that exists here, and the stigma around marijuana in California might be a lot different than it is in other states across the United States. There was a potential for selection bias, given the survey was optional among new patients coming in. And then, like I mentioned previously, the survey allowed for complete anonymity, which precluded any nuanced statistical analysis or us to kind of dive deeper into which patients were using versus not using. Our conclusions here is that topical CBD is an increasingly utilized over-the-counter adjuvant pain medication in patients presenting with arthritic pain. Nearly 3/4 of the users reported some pain relief, and they found it to be very effective, in fact, more effective than medications they had tried prior. And this confirms an interest among patients using CBD for treatment of their arthritic pain, as evidenced by the Megabud store popping up across the street from Mount Zion during my residency. These are my references. Thank you all.
All right, next we have Dr. Avi Chankala, who's going to talk about factors associated with chronic opioid use.
All right. right, so this talk is called The Role of Acute Postoperative Pain Management and Prevention of Prolonged Opioid Use After Orthopedic Surgery. Thanks for the opportunity for presenting. We have no relevant disclosures. So pain, as we just heard from Marcus, is a big issue in orthopedic surgery. And specifically severe pain after orthopedic surgery. Some people will say, if you've had surgery, you're going to have pain. And that's kind of been the old mentality. But I think we can make some good steps towards turning that around. Chronic post-surgical pain globally affects about 10% of patients that have surgery. And chronic opioid use affects about 27% of patients, orthopedic patients at 3 months out. That was a recent study out of Canada. The etiology of the chronic post-surgical pain is multifactorial. It can be mechanical, whether that's from a non-union, malunion, stiffness, post-traumatic arthritis, instability, all sorts of causes. Neuropathic pain, we've heard recently about the connection between mental health and physical health and the connection and how people experience pain. Preoperative chronic pain and preoperative opioid use have been shown to increase postoperative pain. And then more recently, there's been talks about acute postoperative pain leading to chronic pain. So the cycle here is you have acute pain after surgery leading to chronic pain and long-term opioid use and the complications that occur from that long-term use. This is an email we just got yesterday, which was showing that the COVID public health emergency has now been lifted by the CDC as of May 11th, and that the webpage that was dedicated to it is now moving back to the opioid page, which has been in place since 2017. So we went through a whole pandemic and haven't really made any headway on the opioid pandemic. So the aims of the study was to assess the magnitude and risk factors of prolonged opioid use in orthopedic surgery patients, and does acute pain alleviation after surgery make a difference? This is a retrospective cohort study of a single institution's EMR. All patients undergoing orthopedic surgery from 2015 to 2018 at a single institution were included. You had to have a minimum of a 24-hour inpatient stay to monitor for acute pain. So outpatient surgeries were not included. Records were queried for surgery type, body location, basic demographics, medications that were given in the hospital, opioid prescriptions, and length of stay. And chronic opioid use was defined as having a continued opioid prescription at 3, 6, and 9 months after surgery. 11,825 patients were identified in those 3 years, and the chronic opioid use rate, meaning having an opioid prescription at 3 months, was 35%, 6 months 24%, and at 9 months 16%. The demographic predictors of opioid use at those time periods, the biggest odds ratio was uncontrolled acute pain at all 3 time periods. Age less than 65, female sex only at 9 months, ASA classification greater than or equal to 3, an increased comorbidity index, and having baseline preoperative pain were also identified as having increased odd ratios. We looked at medications given while in the hospital, none of which, I think the main points of this that we found was NSAIDs were protective, so you give NSAIDs, which we now do as kind of our multimodal pain regimen for most patients. CBD, unclear, Marcus, if it has an effect. But I think the other key point is opioids did not show any increase, acute opioid use did not show an increase in chronic opioid use. I think a lot of what we think about with decreasing opioids is we say don't give them anything, because it's going to cause long-term use, and that wasn't found to be the case in this case. We looked at surgery types and procedures that were done. Notably here, total joints did the best with limiting chronic opioid prescriptions. And we looked at fracture surgery and looking at ORIF location and opioid use. And thinking about, there wasn't really much difference between the procedures. Tibial plateaus are running ahead with the wind. And, thinking back about our traumaplasty yesterday, maybe plateau ORIF is not a bad procedure. So in conclusion, a high rate of chronic opioid use is present in orthopedic patients, age, sex, ASA class, comorbidities, baseline pain, and uncontrolled acute pain increase the risk of chronic opioid use. The location isn't really as important. Overall, total joints do well with chronic opioid use in terms of risk. And then really, uncontrolled acute pain is the main modifiable risk factor. We can't change someone's age. We can't change some of their comorbidities, but we can change how much pain they're in post-operatively with our multimodal pain protocols. So looking at the similar time period over those 3 years, are we doing a good job at controlling pain, and is it controlled or uncontrolled? And the key here is 25% of our orthopedic patients post-operatively have uncontrolled pain. That was defined by 3 scores of 8 out of 10 or higher, at least 4 hours apart in the first 24-hour period after surgery. So we do have a significant amount of patients that are experiencing uncontrolled pain and some room for improvement there. And then looking at the location for the uncontrolled acute pain, I think spine had the highest odds ratio, but you can see the rest of them here. So I think a little bit of work to be done to help our patients with acute pain. I think the total joints have shown us that a multimodal pain regimen that's established can hopefully decrease that risk. And maybe we can incorporate that into the rest of our practices. Thank you to Dr. Marmer and his group for the work, and to the Abbott Society for hosting this event. Here's my references.
All right, next up, presenting for Dr. Asturias is Abu Bahar Wage, sorry.
My name always, it's always like that.
Talking about where female faculty endowments are in orthopedic surgery.
Awesome. Yeah, thank you for your introduction. And again, thank you for letting me present today. I'm standing in for Dr. Asturias, but I'll try to do her justice in this presentation. So to start off, endowed chairs are among the most coveted faculty positions within a particular field. And they represent unrestricted funding, salary compensation, and administrative support to further a recipient's career and impact within a particular field. And there was a letter published in JAMA, which looked at internal medicine, and they were able to demonstrate that there are gender disparities between endowment recipients in that field. So this got us thinking if we can see if these same inequities manifest in our field, given that orthopedics has a long history of gender disparities. So the goal of our study was to determine if gender is an independent variable for achieving endowment in musculoskeletal medicine. And this is important because orthopedic has the lowest number of full-time faculty positions held by women. And if this is the case, this will represent a new glass ceiling for female orthopedic researchers and providers. And before you can start to discuss solutions to a problem, you must first be able to characterize and understand it. So advocacy always starts with data. So we did a cross-sectional data collection looking at 2 populations, the first one being the top principal investigators in musculoskeletal medicine, which we identified looking at NIH funding. And our second group was the faculty from the top 100 orthopedic residency programs using US News and Doximity rankings. We then utilized publicly available sources such as Scopus and institutional research, institutional websites to determine the endowment, demographics, research, and productivity data. So what did we find? So first, looking at our top MSK researchers, out of the 137 that fit our inclusion criteria, 23 were awarded endowments, with only 1 being awarded to a woman. So this equated to an odds ratio of 11.4. And now when looking at endowed versus not endowed in this group, we saw that endowment recipients are more senior, have increased average funding, publications, and H-index. And for those who are unfamiliar with H-index, this is just supposed to be a measurement of the cumulative scholarly impacts of one's research. It's supposed to take into account both the quality and quantity of publications. So now, when we separate this group by gender, we see that there's no difference in funding between men and women. However, men had a higher H-index and publications. And unfortunately, we were unable to do a separation in gender based on the endowees, given that there's only 1 female recipient in this study. Now looking at our second group, looking at the top orthopedic departments, we saw that endowments were quite rare. Only 4% of orthopedic faculty members received endowments. And of this small percentage, the majority, again, were men with an odds ratio of 2.95. And we really want to highlight here that this is a heterogeneous group. So this doesn't only include orthopedic trained surgeons, but it also includes family medicine, sports physicians. We also included plastic hands and neurosurgery spine as well. So now when looking at just the endowees in this cohort and dividing them by gender, we see that there's no difference across graduation year, age index, or all of our productivity variables. However, once we look at just the orthopedic trained MDs, we begin to see a significant difference in all our variables. And one thing that we really want to highlight here is that when we look at graduation year, there's almost a decade difference between the men and women in the endowed cohort. We then also looked at how endowments were allocated based on specialty. And what we saw was that sports and joints together comprised 35% of all endowments. And when we look even closer and look at specialties that historically had more women, we saw that there were more awardees, but this proportion was not representative of the national distribution. And we also did an interesting analysis looking at the names of the endowments. And of the 194 endowments that were awarded, only 14 highlighted individual female names. So in summary, after our analysis, our results suggest that gender was predictive of endowments for the MSK research cohort and our orthopedic trained MDs. And subspecialties with historically more women represented more female awardees. However, this percentage does not match the national proportions. And we also saw that there were significant differences in gender, in age index, number of publications, and graduation year for the top MSK cohort and orthopedic trained surgeons. However, when you take into account the heterogeneity of orthopedic faculty, this difference begins to disappear. And endowment naming also reflects some gender disparity. There were some limitations in our study. We had to make some assumptions, so we only looked at NIH funding and also just looking at academic rankings. And also publicly available data can sometimes be incomplete and outdated. And age index is not a holistic view of productivity. So we just want to leave you guys with just some final thoughts. So endowments for women in musculoskeletal research in orthopedic surgery is rare. And in this surgery, there are only 13 that received endowments out of the 100 programs that we looked at. And productivity does correlate to endowments. However, seniority may be a modifier, as we saw in our previous slides, that men that were awarded endowments were who graduated decades earlier compared to the female counterparts. And disparities persist at sponsor level, so there's an opportunity for advocacy among donors to address these disparities. And these are some of our references. And thank you again for this opportunity to present at this conference.
Awesome, thank you. So I believe Dr. Ward is running late, so I think we'll probably just skip his presentation and open the floor to questions. So if anyone has any questions, feel free to come up to the mic. Maybe for Dr. Stroud, in your registry study, were you able to get any granularity about where patients got their care, whether or not that affected their outcome?
We have one variable, yes. So we can see if on a binary scale, if someone was ever treated at an NCI designated cancer center in their course, it is associated with lower odds of mortality, lower hazards of mortality. We didn't see a racial difference there, but it's a really limited variable, and so we didn't discuss it as much.
Well, thank you. Thanks for a great series of papers. And Abby, I don't know if you know the guy to your left there, but he's doing some really good work on opiates and postoperative pain. And to that end, I'm going to ask you a question that he knows the answer for in spine. But of the patients who are on opiates preoperatively, what's the likelihood of them getting off of opiates postoperatively? And have we demonstrated that any protocols, opiate sparing protocols, might actually help the likelihood of being off opiates within 3 to 6 months after surgery?
Yeah, so this study didn't look at the likelihood of how long, how many people that were on pre-op opiates actually were part of that chronic pain group. But I think we do have protocols here that we do use on patients that have a preoperative opioid use across multiple subspecialties. Most people would say at least decrease by 50% and work with a pain management specialist before you're indicated for an elective procedure. Obviously, it's different in a trauma setting, but for most elective procedures, that's generally been the protocol.
I hope you and Abubakar get to talk, because you guys, not now, but afterwards, because you have a lot in common.
Another question for Sarah. I was actually really alarmed by your findings. And maybe I missed this, but did you guys look at whether some of those results were mediated through a time to presentation or a time to diagnosis? I mean, you made some, I think, very plausible hypotheses about payer status and that sort of thing, but I'm really wondering if that was mediated through just a time to presentation or appropriate diagnosis.
Yeah, so our database doesn't capture that. That's one of my major hypotheses as well, and I'm really grateful that you brought that up, because stage was the most important interacting variable for our patients. We do know, interestingly, that Black patients with these sarcomas are diagnosed at younger ages and at later stages. So that's clearly, our screening tests aren't great right now, and so that's clearly a huge open area for research and intervention.
Hi, I have loud. Sorry, this is a question to Dr. Jangala. Am I pronouncing that correct? Yeah. So your major finding is that uncontrolled pain was most predictive of chronic opioid use.
Yes, acute pain.
Acute pain, right? So, do you have any way of knowing whether those patients with acute pain were being treated in some different way, and that's why they had it, or is it that they're just intrinsically more pain sensitive, let's say?
Yeah, I don't think we can have that level of granularity with this data in terms of were they being treated differently. Specifically, were those individuals that had increased pain scores being treated differently? Most patients undergo a similar pain protocol and a pain regimen, depending on the service that they're on, and all those are, written by residents or PAs following one of our order sets. And so, is it the patient that's experiencing more pain, or is it that they're not getting adequate pain control? I think it's kind of a chicken or the egg situation, and we need some more data to really distinguish that.
And just to follow up on that question, what do you think the role of culture plays into this? Because we seem to be unique as a country in our opioid prescription patterns and chronic opioid use after standard elective orthopedic operations, where in other countries they're not even prescribing opioids. So what are we saying is uncontrolled pain, and what are your thoughts on that?
Yeah, that's a very interesting, and I had a similar thought, like you said, in other places they either don't have access to or they're told they're not going to get anything stronger than Tylenol. And I think culture does play a big role. And I think the understanding of, like I said, the first thing I said was, if you have surgery, you're going to have pain. And, is our culture that we can control all that pain and being pain-free the goal, or is an 8 out of 10 different between someone who lives here and someone who lives in Scandinavia? Maybe, but that's definitely, I do think it plays a role.
So in my private practice, before surgery, I spent a lot of time talking about pain management after surgery, and pretty much don't prescribe narcotics. We give a little bit, but mostly it's ketorolac, which we can't use at the VA. It's out of formulary. And I think in the last 10 years, probably I can count on one hand how many times I've given a prescription for narcotic more than once. And I think what your paper shows, and I think that the community knows, is that we need to spend more time with the patients before surgery to assess kind of how much we need to give them afterwards, because a lot of times patients wake up after surgery and they have 3 bottles of prescriptions, they don't know what to do with them. And so they just start taking everything and they don't know what to take. And I think we just need to spend more time discussing with the patients ahead of time, just like we do with surgery, how to do pain management. And also what's available. Most people don't realize you can give ketorolac orally, but it's not on formulary. And don't give it long, it's not good for the kidneys. But there are other drugs you can give besides narcotics. But really great study, Abhi.
Thanks. Yeah, and I think expectations play a big role in everything we do, whether that's outcomes or pain management. Expectations can, in a discussion with the patient, can always set the stage.
Great, thank you so much. So we're going to take a quick 8 to 10 minute break. When we come back, we're going to do our final raffle. Odds are good. The goods are good. So please get all your signatures and submit it to the raffle. Thanks so much.